Hi, dear colleagues. Welcome back to Dental Arena. It's an honor and pleasure to have here with us Robert Nordquist, which was a leading figure in the last 35 years in dental business. He was a director of marketing at Dental East, also at Colteen, and he was responsible for merging the Colteen and Welldent, and then was vice president at Ultradent, and currently he is vice president sales and marketing at Centrix Dental. Welcome, Bob.
Thank you very much. It's a pleasure to be here.
I want to tell us some words about who is Centrix, and some words about the company, the concept, how it started all.
So Centrix is a 50-year-old company, started by a dentist, a Dr. William Dragon, who actually comes from Eastern Europe and in this area. He was a practicing dentist who found ways to improve the flow of dental materials to the tooth. His very first products were the composite guns that we all see and are used every day now, and the tubes that go with it that hold the composite material or many other restorative materials. And this allowed the dentist for the first time to inject directly into the preparation, to the bottom of the preparation, to avoid entrapment of air and bubbles and enable a higher quality restoration and make the process go faster and easier for the dentist and their assistants. That was our beginning products, and since that time we've introduced several other revolutionary products that changed the application of dental materials. The most recent of one is an impression material called No Cord VPS, an asilicone material. And this is a material that is unlike any other impression material, and we'll talk about that more.
Yeah, we'll talk about that soon. Question that is quite often from dentists from Romania, and maybe a lot of misconception will be how different it's the US market from the one in Europe, and especially from the one in Romania. Are the dentists in US using different kind of materials? Are the dentistry in US more advanced or totally different than the one in Europe? And because you were in this business for quite a long time, and you travel a lot, what can you tell us? Where is Romania? Where is Europe? Where is US? What are the needs?
So one of the pleasures of my job is I do get to travel quite a bit. So far in the last 3 months, I've been in Australia and in Thailand, Korea and Japan, as well as Germany for a conference, and here today in Romania. And what I find is the quality of dentistry everywhere you go is at high standards. Romania is no different to me than Germany or to the US. The biggest difference, though, is how the dentist is paid. The reimbursement system approaches from the national health systems or from the private systems drives the treatments that are done, and to a lesser extent the materials that are done. Across the world we see the same kinds of materials, the same quality of materials, and the same quality of dentistry. It is really just how the dentist gets paid. A very important part, because we need to earn what our time is worth. And so we take care of our families properly, and that makes us take care of our patients properly.
I'm 100% agree with you on that. Regarding composite, for example, the Romanian market, the dentists in Romania will use in the same percentage high quality composites, just like any other dentist in Germany. Of course, we will have some dentists that will use cheaper composite, but it's the same, the percentage all over the world, as much as I can tell. Where I see a difference will be, for example, in prosthodontics, the crown and bridges. In US, I saw that PFM are almost an extinct dinosaur.
Yes.
I think only a few % of the dentists in US will place right now metalloceramic. In Romania, right now is the norm. It's really expensive for a regular and average person to afford the zirconia or even Emax crown. So the norm will be PFM right now in Romania.
It's true worldwide, and it really comes back to how does the patient have to pay for the treatment, and what is their ability to pay. And if there is reimbursement from any kind of a national health program, these drive the materials that the dentist is using and the treatments that are offered. For example, one really important area of treatment is the whole area of prevention. And yet it's less often applied in Romania and other countries where the reimbursement is not available to. Even in the United States, where there is a lot of prevention done for children, on adults it's not provided anywhere as often, and because there's not reimbursement for that procedure. So basically, dentists around the world deliver the kind of treatment for which the patient is able and can afford to pay.
So the money, it's the key factor again here in dentistry.
The saying that follow the money, it's true in everything, including dentistry.
Yeah, and because we spoke about money, let's talk a little bit about digital impressioning, because a few years ago that was like the future, like near future, like in 5 years from now, every dentist will use exclusively digital imaging. No one will use regular impression material. There is also the misconception that in US most of the dentists right now are using intraoral scanner. No one is doing regular impression technique. What is the truth?
Well, the truth is that going digital is a great thing for the dentist and the patient for many good reasons. But whether you're going digital through intraoral scanning or extraoral scanning, both get you to the same place as easily. The belief was intraoral scanning would be replacing analog materials very rapidly. And so they grew initially well. Then we have seen now in the last couple of years that the adoption rate has leveled off to only about 18% of dental offices have adopted intraoral scanning. Interestingly, and led by Europe, we now see an increase in extraoral scanning or impression scanning, where you take an impression in the normal manner using analog materials and then either scan the impression or perhaps better yet, scan the model itself after you've created that stone model. This allows the dentist to be able, and the laboratory to be able to correct problems in the anatomy or even in the impression more easily than the limitations of an intraoral scan. Still, for any dentist and for any patient, the ability to scan and digitize is a great tool for I understand my patient's records today, and I can save that record and compare their oral health changes over the life of that patient. So I can easily track their oral health status and what has changed. That is a fantastic opportunity. But that could occur through intraoral scanning or extraoral scanning.
So we are still using a lot of regular impression material today?
Actually, the total consumption of regular impression material continues to grow. There was concern that it would go away, and it's not going away because of the rise now of extraoral scanning. So again, the dentist uses their preferred impression material and takes the impression in a normal manner, and then scans either the impression or after they've poured the model, they'll scan that, or the laboratory will scan that.
Talking a little bit about regular impression material, are dentists in US using more polyether compared with the VPS than Europe? For example, in Romania, most majority of the dentists will use C-silicone. C-silicone, I spoke in US with some dentists. They said it's something old. They didn't use that for a while. Still, it's almost the norm. Of course, don't have the same definition as VPS or polyether. How is the US market?
So when I began in dentistry about 35 years ago, C-silicone at that time was already fading in use in the United States. Today, it would be rarely used clinically, if ever, I would say. A-silicone is the primary material used. Polyether is less than 20%, about 20% of the consumption of materials. There are great advantages to a polyether, but the biggest disadvantage, frankly, is the patient reaction to it. The taste is so strong and the patient reaction is so bad that dentists have realized they get the same results with an A-silicone material and without having a problem from the patient's point of view. So in the U.S., it's A-silicone materials. In the U.S., we call those VPS or vinyl polysiloxane. Same material. And that is what's growing today.
I want to talk a little bit about tissue management right now, and also VPS material from Centrix about no cord, which is a totally different approach to the regular impression and technique, and basically replacing or be a complementary technique to retraction cord. Tell us a few words about Centrix.
Any impression is only as good as how well you manage the tissue. If there's tissue that overlaps and does not expose the margin well enough, if there are fluids remaining in the sulcus or blood that continues to come out from the sulcus, you can trap air and bubbles, and you get an incomplete capture of the margin. So the first and most important step in managing the tissue is good tissue management and to result in a good impression. Still, there's about 20% of the dentists who never use any retraction material at all, whether it's paste or retraction cord. Recognizing this, Centrix has pioneered a brand new kind of material to make it easier for the dentist to both manage the tissue, manage the fluids that are in the sulcus, and result in a quality impression. We call this no-cord VPS. Again, VPS, asilicone material. The wash material, the light body material, has an astringent built into that wash, so that when it's against the tissue, the astringent is against all the cut capillaries and causes the capillaries to constrict and bleeding to stop. The very interesting part is how the tray material sets, and it's the rate at which it sets, because it firms a little faster than the light body wash material, and allows it to create more dynamic drive, more mechanical movement of the tissue away from the tooth. As you expand the sulcus, the wash is able to penetrate, and you're able to capture a high quality impression. What we find is that it's an ideal material for almost any kind of impression, but like every material, the dentist has to understand how it's used in their hands, and what their technique allows them to do. So while we call it no cord, for many cases, I would still recommend that cord be used. If I have a multiple units, more than 2 units, for example, a large roundhouse case, it is better to apply at least 1 cord. If you apply 2 cords and pull that top cord, you'll always have a few bleeders. But then place your wash, because it's like it has a restringent in it. And then seat your tray, so now you'll have mechanical compression as well as chemical cessation of the bleeding, and you'll obtain a high quality impression as a result. So as with every material a dentist uses, it's how they manage their technique. I would recommend that no cord is outstanding without any retraction paste or cord when you're super gingival, or when your margins are even equigingival. No cord is also an outstanding material when you are concerned about the health of the tissue. If you have a patient who had periodontal surgery within the last year or so, and you're concerned about the attachment, no cord provides more protection for the gingiva. You no longer need to go into the sulcus with a packer and risk damaging the epithelial attachment. So no cord offers many advantages, but the dentist still has to take the responsibility of learning the right use of that material, and for each patient, each case.
So basically you adapt the material to your actual situation. It will not be a recipe for every case. Every dentist knows every patient, even on the same patient, every tooth is different. You need different approaches. It will not replace in every case the retraction cord, because sometimes when you have a subgingival margin, you have to place the first cord just to push the gingiva away, not to cut it with the burr when you are preparing the tooth. That placement of the retraction cord is not necessary for the impression itself, but mostly for the preparation. After that, if your margin is way too much above below the gingiva, you can use the second cord, or you can use an astringent paste if you have really high bleeding or inflamed tissue. So So basically it's a VPS, it's a regular impression material, a silicone, with the added benefit of astringent inside, yeah?
That's correct. And we do recommend the use of the wash and the tray material together solely because of the setting profile of the tray material. There's at least one other impression material in the market where their tray material has a similar profile. Then they can be combined, yes. But if you use a traditional material with a smoother curve of setting profile, you won't get that push of the soft tissue moving away from the hard tissue. Dentists will not be surprised to know that sometimes manufacturers want to say that their product solves all potential problems. And that's just not reality. Every case is unique and different. The use of any material in any situation is always dependent on that specific case. It's the same with no cord. But what no cord does is provide the dentist more options, and especially as they learn the strengths of the material, they realize that there are more and more situations where they can eliminate the time it takes to place retraction cord, the discomfort it takes for the patient to have cord placed on them, and get the same high quality result. So no cord is a tool that allows a dentist to be able to be more flexible in their treatment of the patient and be able to save time and money in their procedures.
Most of the dentists that I know, they are hating packing cord. Sometimes
most of the patients I know are hating having cord packed.
Sometimes you'll not be able to place a cord. You'll have such small tissue, so basically placing a cord will mean destroying the dental ligament. And I know Centrix is a pioneer in gingival retraction. Before no cord, it was Gingitrack. Before Gingitrack, it was another product.
Correct.
They also have Access Edge and Access Flow, which are a clay-based retraction material. So basically, Centrix has a portfolio for gingival management and bleeding. How no cord, because it's a VPS with astringent, competes or integrate with Access Edge, Access Flow, and Gingitrack?
Well, so for manufacturers, it's often believed that all we want to do is sell product without regard to how the dentist practices dentistry. If that was the case, I may not offer 3 different retraction pastes as well as an impression material that can build in the retraction into the material. I would cannibalize sales from one versus the other. But in fact, the dentist needs to have many tools based on the case in front of them. No cord is somewhat case specific. It's a great impression material in every case as long as you manage the tissue properly in every case. We have a vinyl polysiloxane or asilicone retraction paste, Gingitrack. Today, I think that is an outstanding material, particularly when you're doing digital impression, because it pulls away from the arch cleanly without leaving debris in the sulcus, and so it's easier for the dentist to remove that, have the tissue stay away from the tooth, and be able to capture that digital impression. We offer 2 different types of clay retraction paste. One is much more viscous, that's our Access Edge. One is much more flowable, that's our Access Flow. And again, that is based on what the dentist needs. I know many dentists who use both Access Edge and Access Flow, and it depends, do I need to penetrate more into the sulcus in this case, or do I need more mechanical pressure with a more viscous material that helps to push tissue away? That is something we can't decide for the dentist.
That's true.
It is a case by case. You know this, you do this every day with your patients. But having the different tools, you now have a hammer when you have a nail. You have a screwdriver when you have a screw to place. So for each case, we have the right materials, or try to have the right materials for that patient, that case, that day.
And it's a lot about the dentist preferences. Myself, I will use a lot of Access Edge. My colleague will use Access Flow because he will like more the consistency. So it's same. It's clay-based material, also astringent inside. But also there are great help when you need to dry the sulcus, not only for gingival retraction to take an impression, but for example when you are cementing a veneer, because you want to dry sulcus, sometimes you are not able able to place a rubber dam because the margin will be way too deep. So by placing a clamp over the tooth, you'll cause only more bleeding. So even if you are causing some bleeding, you can use this paste to stop the bleeding and also dry the sulcus, and you'll have no interference with adhesive procedure and cementation of veneer.
Well, and further, just on the preparation itself, depending on the case, you may want to place a retraction paste or even a retraction cord just to move the tissue away so that if you have to go subgingivally, the tissue's not in the way. Rotary curettage is not a good solution. So we want to move the tissue away. An easy way to do that is place the right paste, use a compression cap to give you mechanical pressure as well, and that will help to move the tissue away. Now you have an open, dry sulcus, and you have easy access to prepare that tooth to the margin that you feel is necessary for that case.
So now I would like to talk a little bit about the post-endodontic treatment. This is a big topic in dentistry. Maybe we'll talk a little bit about who is in charge to place a glass fiber post inside the root canal. A lot of time you will have referring dentists send the patient to an endodontist. The endodontist, of course, will perform the endodontic treatment. And a lot of the referring dentists will say, okay, you just make the root canal treatment, just fill the root canal, and myself, I will place the post and I will make the core buildup. In my opinion, it's really important, and all the time the post inside the root canal should be placed by endodontist once they made the root canal treatment, because I assume an endodontist will have magnification, at least some loop, if not even a dental microscope. The endodontist will know in depth every part of the root canal. They will know how long it is, the root, how large is the root. So for me, there is no discussion here. The endodontist should place the post inside the root canal as part of the endodontic treatment. We know that is not the norm all over the world. Centrix has Anchor DC Minimix. Centrix has also Connexio. Centrix has Expose. So basically, it's a line of products designed for post-endodontic treatment. I know soon you'll have an expansion of line, also designed for post-endodontic treatment to complete. Tell us some words about how Centrix is seeing this area post-endodontic treatment. What product do you recommend to the dentist? Maybe technique. Please tell us some.
So I largely agree with your idea that the endodontist, but really it's the dentist who does the endodontics ought to place the post and build the core. And the reason for that is they are most intimately familiar with the shape of that canal and how large they've built that canal. If you then take that patient and don't do the post core and you refer that to a general practitioner, refer back to the general practitioner, they will not be so knowledgeable, and that's when we see errors that happen and perforations and the like that occur. So I completely agree. In the best case, it should be the dentist who does the preparation of the canal. Still, particularly in the United States, where we have a large population of endodontists, and we find that general practitioners refer to the endodontics to the endodontist almost always sends the post-core back for the GP to do because they don't want to disrupt the referral relationship. That's unfortunate because this is a case where, a procedure where intimate knowledge of the shape of the canal and how the endodontist left it is critical to long-term success. My own background in post-cores began with Whaledent, as we mentioned before. Whaledent was the inventor, the founder of Whaledent was the inventor of the Parapost. And that line of posts today still remains the most widely used post-core system in the world. So I think I have strong familiarity in this area. In my early days, there was discussion, did the post strengthen the tooth? It does not. But what it does, though, is distribute the forces of the tooth. In today's world of adhesive dentistry, now post-endodontic therapy takes on a whole new meaning. We have the ability to bond together the tooth to the cement or the core material to the post to the final restoration. And now we have a very intimately connected post-core tooth system. I call it a monoblock restoration. And this allows more perfect, more ideal distribution of occlusal forces and the greatest opportunity for success. There's still some keys into doing great post-core restorations. And probably the most important element is the ferrule. Do you have enough of a ferrule? Do you have enough of material within the tooth? Essentially, I go back to structural integrity. Structural integrity means my goal is to leave as much dentin behind as possible, or said the other way, is to remove as little as possible. If I've done the endodontics myself, then I realize how much material is left in the tooth. I will look at that tooth and understand, are there any caries remaining in that canal? Then I must remove only as much as I need to have minimal amount of caries, whether it's, my belief is complete caries removal or selective caries removal. But how do you know? We can have clinical judgment, yes, it's fantastic. But if there's a tool that tells you that you have remaining caries, wouldn't you be better off to know that in fact you've attained your goal, whether it's complete caries removal or selective caries removal? Because selective caries removal is dependent upon a border of healthy dentin surrounding that carious lesion. Then when I cover it up and I put it into an anaerobic environment, the bacteria will die and the lesion will no longer be a threat to the tooth. How do you know? And you don't know if you rely only on clinical judgment. We have developed a product that enables the dentist to be able to identify if there's carious material remaining through a simple device. We call that expose for exposing the remaining caries. And it's a simple dye dried onto our Benda microbrush that is, when touched to a wet lesion, will stain the carious material. It won't stain the healthy material, just the carious material. When you rinse it away, you can see if that material is carious or not. There's a blue dye and there's a red dye because in different clinical situations, red may not be the right color for you. You may need to have blue. If you're close to the pulp chamber, it'll look more red. You wouldn't want to use a red in that case. But if you have an old amalgam restoration that you've removed, you're going to have dark staining already, so blue may not be enough of a contrast. So we have different choices. The most important is that the dentist is sure that whatever their goal for caries removal has been achieved. Now, when we talk about post-endo treatment, again, the dentist who did the endodontics is probably the correct person to do that post-core therapy. Then from all the research I've read, says that the post that ought to go into that tooth should be one that passively fits in that canal to whatever size the dentist, endodontist or general practitioner, whatever size they've increased that canal. It fits passively into the canal, and then you use your cement. We would recommend a dual cure cement because you're going to be deep into the canal where a light cannot reach.
That's for sure.
You want to ensure that all the material has been fully cured. And if you're going to use a dual cure material, then you really need to use a dual curing bonding agent to hold that all together. So again, deep into the canal, you're sure that everything is fully polymerized and that you have a solid monoblock restoration. So our dual cure core buildup material and post cement material we call Encore DC, DC for dual cure. Our dual cure bonding agent is called Connexio. And again, with that product, you have both the activator and the dual curing activator as well, so that all the materials that you need to have to do an effective post-core are in the package. And again, we would say, you want to first make sure that your caries is managed the way you want it managed, and that you know that you're sure, and then you can easily place your cement. You seat your post passively, and then when you cure it, both light cure it at the coronal end and it's self-curing at the apical end, You now have a fully cured, fully bonded monoblock restoration that will well distribute the forces, always ensuring that you have a good ferrule at the coronal end. But if you're not sure if you've had the right caries removal, you'll remove more dentin than you would ideally like to have done. Now you've compromised the structural integrity of the tooth. These tools allow a dentist to do exactly what they know they want to do. But because tools have not been there to help them in this procedure, they relied solely on clinical judgment. Now there are tools available that are easy to use, low cost to use, and the dentist can be sure.
Yeah, I'm a big fan of exposing, and I can tell even by using a dental microscope. So you are working with something like a 20 times magnification. It's so hard sometimes to tell which is pigmented, which is infected, which is affected, which is sound dentin. I learned in dental school just to take an explorer and touch the dentin, and you will feel some soft dentin. I can tell you cannot feel 20 microns of infected dentin. If that will stay there, that infected dentin can affect your work later.
Yes.
Or if you see too much pigmented dentin and you are too vigorous, you'll take a burr and start to remove all that it's pigmented. Sometimes you are removing sound dentin.
Sound dentin that's stained but not infected.
Yeah. So it's a paramount importance to remove only that it's infected, and that's why carie indicator, carie detector, it's so important, even when you are using a dental microscope. From your advice, it's on par with some study that I read, and also the indication will be always choose the glass fiber post or the post that you are using, even if it's a carbon titanium, based on the root canal. Never make a root canal fit the glass fiber post that you are having, because sometimes, for example, you already perform the endodontic treatment, you already enlarge the root canal, so leave that root canal enlarged, just clean the sealer from inside the root canal, then take a glass fiber post that will fit your root canal. Don't make your root canal fit the glass fiber post. That will be really important. And some studies that I read also, the main failure when you are performing a adhesive core buildup, the number one, 98%, it's decimentation. And why? Because most of dentists, maybe they don't know, maybe because of the marketing from a dental producer, they are using regular bonding inside the root canal. There is no way light will reach inside the root canal, and especially in the dentinal tuberous and the microretentivities, that will cure regular, only a light cure bonding. So always inside the root canal, you need a dual cure bonding, and keep in mind that most of the bonding, or at least a part of them, are not chemically compatible with a dual cure composite. Basically, they will inhibit the setting reaction of dual cure composite because of the low pH will destroy the catalyst. So the right way of doing the core buildup will be to use a complete family. So in this case, if you are using Connexio with Anchor, you know for sure they are 100% compatible, and you'll have a success. And in my experience, in I don't know, in the last 5 years, I start to count, to write every patient and every core buildup that I made. I've seen only 3 failures. 2 of them were on the lateral incisor with insufficient ferrule effect, and 1 it was on a central incisor with extension. So basically, I didn't have anti-rotational lock on that tooth. But I never seen a fracture, a catastrophic failure, even on those 2 lateral incisor. I was able to save the teeth. It's important when you are placing a post inside the root canal and you are performing adhesive core buildup, you all the time you will strengthen the tooth and you will decrease significantly the risk of catastrophic failure. When I mean in the catastrophic, I mean basically breaking the tooth under the gingival line.
You will. You'll, as much as 2/3 of the way down the length of the root itself. So this is an area of such great change over my years in dentistry. When I began with Parapost, it was a stainless steel post cemented in place with zinc phosphate. what a change, and it's all because of the new materials have allowed that change to occur. As we moved into the world of adhesive dentistry and bonding became the standard way of caring for any restoration, then the opportunity for a glass fiber post that would allow it to bond chemically with the bonding agent and then secure itself to the dentin in the root was a way of increasing the quality of that restoration, the longevity of that restoration, helping to guard against the root fracture that you just mentioned. We went back from the earliest days of the research with Doctors Nathanson or Dr. Caputo on the stress research or any number of dentists in the old ways of doing things. And today, those same dentists will show you that the data says a bonded post-core is the most effective treatment. But then you, like every other technique, you need to use the right materials. Too many dentists will say, I have a bonding agent in my office that I use for my direct composites. Fantastic, I'll use that deep into the canal as well. It's a light cure material. The light does not reach deep into the canal. We may have chemistry incompatibility between the restorative material or the kind of cement that's being used and the bonding agent. So the dentist needs to look now at what's different in these materials. It's why we built our line so that these were compatible with each other, that if you selected Encore DC and Connexio, you knew that they were compatible, enabled a full polymerization of materials all the way deep into the canal, and that they would stay compatible. We find that with Encore DC, fantastic material, but if I use a traditional light cured only material meant for direct composite restorations, the results are not the same. Right? So it's important, as with every other procedure, as with every other set of materials, the dentist pays attention to this bonding material. And not all bonding materials are the same for the different kinds of situations.
That's true.
So we tried to build a line that made it easy. Dr. Dragon, when he formed the company, and until today, he's still active in the company, his belief, his mission is making dentistry easier. And we can make it certainly more complicated. But making it easier says we recommend the correct bonding, the type of bonding material with the correct post-core material, and that we link these all together.
So basically, being a family, you are guaranteed that will work together. They will work every time. Because for a dentist, it will be quite hard to take bonding from company X associated with the core buildup for company Z, and then read all the instructions when they are compatible, where they are not. So by using from the same family, you are 100% that this is the right way of using the material.
I love the term guaranteed. I cannot use the term guaranteed because there's always things that can go wrong, both in the application of the materials.
That's true. Isolation, I will not.
So there's a lot of issues that get involved. But you're right that when the company has worked to pair one material with its counterpart, and they work to test and ensure that these two materials work together, at least the dentist knows that in this case they will work together. Are there other things one could use? Most likely there are. But which ones? Then now the dentist has to go do the research behind that to say, if this is my preferred core buildup material, then what's the compatible bonding agent? In our case, we tried to make it easier by ensuring that we had the right bonding material with the right core buildup material. And that we know that it will work with glass fiber posts as well.
So right now I want to talk a little bit about prevention. How it's in United States done, the prevention. I know you have a large program for children, but now also for adults. How is the prevention in Europe? Because I have a colleague in Germany, in Poland. I know that, for example, in Poland there will be much more prevention done for children compared with Romania. I will tell the truth. In Romania, we are not so much prevention. The fluoride varnish is not that used. how it used to be, or as it should. How you are doing in US? What Romania can improve in this area to catch up with the rest of the world?
This is perhaps the area of dentistry that I'm most passionate about. And the value of preventive services goes beyond just that individual tooth. We know today that oral health is directly related to systemic health, that we find oral bacteria, oral plaque, is part of the plaque buildup in the arteries leading to one's heart. We know that oral health and inflammation is directly related to pregnancy-related issues, preterm birth and low birth weight babies. We know that oral health and oral conditions are directly related to some types of cancers. So the oral health conditions affect systemic health, the whole health of the patient. And so in dentistry, we too have historically viewed the mouth as somewhat separate from the whole body. The medical profession has also tended to view the mouth and what dentists do as separate from the rest of the body and its health. Unfortunately, that has led to poor overall systemic outcomes than if we include oral health as part of systemic health. So prevention to me is the key in doing that. In the United States, there's a lot more prevention performed than I believe anywhere else in the world. And today we see that the rate of caries for children, for under 18s, has been declining. That's fantastic, and it's directly related to the amount of preventive care that's done. But as we said at the beginning, this is still, every treatment area is driven by how the dentist is reimbursed. And I think in Romania, there's little or no reimbursement for preventive cares. In some other countries, there is reduced reimbursement for preventive care. In the United States and many other countries with national health systems or other insurance systems, reimbursement stops at age 18. So now in the US, we see an increasing rate of caries on those over 18. And that rate of increase increases as patients get older. When I go to countries like Japan, where now the percentage of the population that's over 65 is dramatically higher than anywhere else in the world, they worry about the cost to the healthcare system, overall healthcare system, of the restorative care that's going to be required for those older adults, because prevention was not done on them. So now the Japanese government and our partners in Japan are looking at how can we bring an adequate level of reimbursement, because frankly the level of reimbursement in Japan is so small that it's almost like buying a cup of coffee. It's just inconsequential for the need of the patient. But these are areas that we're actively involved in and trying to gain change, because if we drive greater preventive care, we will see greater systemic health for the patients, the ultimate goal. So in the United States, we have a range of preventive products, but the primary product is our Fluoridose fluoride varnish. Fluoride varnishes over the last 5 to 8 years have completely replaced the use of fluoride gels in trays. According to the American Dental Association, only fluoride varnishes should be used on children under 6 years old, and that fluoride gel in trays or fluoride varnish can be used on patients older than that. The problem with fluoride gel in trays is that it needs to be in the mouth for at least 4 minutes. And you must have continuous suction at the same time so that the patient doesn't swallow a harmful amount of that fluoride. With a fluoride varnish, you have the same uptake benefit that you might have with the gel, but without the fear of swallowing all that fluoride. Plus, instead of 4 minutes for the application, the typical application of a fluoride varnish should be done in under a minute, somewhere between 30 and 45 seconds. It does not require the dentist, assistant, or hygienist to act like a Van Gogh and meticulously paint on every tooth. It is actually 4 broad stripes on the buccal surfaces, 4 broad stripes on the lingual surfaces of the teeth, and perhaps across the occlusal surfaces as well. And it's just that level of application that is needed. The varnish then wicks between the teeth and provides the recharging of saliva so that there's the fluoride reservoir built back into the mouth. So there's no reason why a fluoride varnish treatment can't be done at the end of every dental appointment, so that the patient is covered and they receive that fluoride care that prevents the growth of caries. If you've had a carious lesion in your mouth in the last 2 years, you're considered high risk, and you need to go 2 more years after that without any caries to know that you're caries free. In my own mouth, I found my dentist found a lesion under an old amalgam restoration in a third molar on number 32. They opted to recommend extraction of that third molar, and I had 3 third molars extracted at that point in time. Right? But I clearly still had caries in my mouth. When I went back for my next recare appointment 6 months later, my hygienist said, well, you don't really need to have a fluoride varnish. And we discussed the science, we discussed the literature on this, and she still had the belief that we were taking money from the patient, instead of viewing the application of a varnish as a way of me being healthier. And if they had explained it to me that way, then whatever fee they were going to charge would have been something I would easily accept. If they just say, we're going to apply this and it's going to cost you some amount more of money, then I wouldn't understand why. But if they can explain it, then I'm willing to accept that treatment. And we find that everywhere. If the dentist, the hygienist, or the assistant have that conversation of why it's important, then patients are willing to accept it. Certainly, in my case, on my next recare appointment, they found a proximal lesion on number 17. Again, it's a lesion I did not need to have, but it was brought on because they weren't regularly applying fluoride varnish. And I'm a patient who's more educated than most and want this to be applied. So the prevention to me is an area that is a must application for all dentists, all countries worldwide, if we want to improve overall systemic health. I fully understand the concern if I'm not being reimbursed for that treatment. But what does it cost? For a single dose of fluoride varnish in Romania, what is that price to the dentist today?
It's quite low. It's 3.5 RON, so basically it's under $1. The cost for the dentist, but the benefit for the patient is quite high.
So the material cost is under $1, and the time to apply it when the patient is already in your chair
it will be 30 seconds.
Is 30 seconds. That cost of the practice is minimal. So, if you charge 10 or 20 lei, you would still be able to recover all of that cost, plus a small profit, plus deliver greater health for your patient, and they can leave understanding the extra work that you did to take care of that patient. This is the kind of message we're trying to drive through our marketing. So in our marketing now, we have adopted a program we call Prevention for Life. And Prevention for Life says that we treat the first time a tooth appears in a baby, so roughly at about age 1. So from first tooth to last tooth, we want to be able to, we recommend the application of fluoride varnish whenever the patient is at medium or high risk, but especially at high risk. We need to address this for adults as well and not pretend that there's not a need. Today for adults, most of us are taking some kind of medication for heart disease, hypertension, or any kind of mental health issue, diabetes related. All these medications have the potential to cause xerostomia. It's been identified somewhere over 500 regularly consumed medications cause xerostomia. As we age, we see more recession. With more recession, I have exposure of cementin and possibly dentin as well. Ideal sites for bacteria to reside and then cause destruction. So now the destruction I have is root caries, not occlusal caries. Occlusal caries being easier to treat than advanced root caries.
Yeah.
So the application of fluoride varnish becomes more critical to prevent long-term needs of restorative care for the patient. As your patient gets older, and then they reduce the amount of visits that they have to the dental office, the restorative requirements go up because the oral health treatment goes down even further. We find patients that go to nursing homes or long-term care facilities stop having good personal oral hygiene. They soon develop root caries. They soon find exfoliation or loss of a tooth. And frankly, death is not that far afterwards. It's not caused by the individual loss of a tooth or the individual development of caries, but of part of the impact of that whole process that has changed as we are aging. So if I sound like I'm a little bit passionate in this area, absolutely. Will we ever rid the world of caries completely? No, but we can rid ourselves of unnecessary caries and unnecessary treatment. I know years ago in the United States, dentists were concerned that we won't have any need to do more dentistry because there will be reduced caries.
That's a big argument, and I heard that a lot in Romania and other countries also. Not officially recognized by the dentists, but some of them will say, if I will start to make a lot of prevention, I will apply a lot of fluoride, who's going to make cavities? From making applying fluoride varnish, I don't know, I will make $10 US. On the other side, I will place a composite filling. I will get some money. That composite filling in years will deteriorate. That tooth will need a core and build up. In the end, I will place a crown. I will make less money.
Yeah.
This is a thing, and it's an actual real thing for which a lot of dentists maybe are not applying varnish. And also it's quite a huge campaign, just like anti-vaxxers that are saying that fluoride is causing a lot of issues. We are having tons of studies that are not. There is no a scientific study that said fluoride varnish will cause some general issues. So
you're absolutely right. And what we see these kinds of campaigns exist around the world. I just came from Australia last month, and there's a campaign for anti-fluoride, and they want to reduce even the amount of fluoride that's placed into water. Who's leading that campaign? It's a chef. He has a TV show. And for whatever reason, he's decided, with no science behind him, that fluoride must not be good. Perhaps they saw that if I consume too much of it, it's toxic. That's true of so many things. Frankly, you can consume too much water, and it's unhealthy for you.
You can die from.
So we have this non-scientifically treated based approach that we on the science side, especially dentists who are scientists, who need to lead this fight, will show that the prevention and the use of fluoride varnish is a healthy thing for patients. Now, the question of, will it mean I won't have any work to do? On the contrary, it was absolutely the same concern in the United States. And what we saw is that patients, now when their mouth got healthier, then they wanted their mouth to look more beautiful.
Yeah, that's true.
And as I wanted to look more beautiful, I did more orthodontics or more Invisalign style treatments. I wanted to have the colors of my teeth brightened and not stained as they were. I wanted to have the shape of my teeth look more natural, look like others who I think look beautiful. I wanted my smile to look beautiful like that. So we found instead in the U.S. that the demand for dental care increased, but it increased in the areas of the higher end procedures, more direct composites, more indirect restorative work, things that were actually more expensive for the patient, but they valued them more because they were healthier. They didn't only view dentistry as something that when I was in pain. Now dentistry makes me look good and feel good, and I feel good about myself. So the idea that if I do more prevention, it's going to reduce my work, that's the same kind of unscientific belief that the idea that fluoride is not good for patients. It's none of the science, none of the data supports that at all, anywhere in the world that I've been.
Yeah, what I want dentists to understand is if they will do prevention, this will not mean that they will lose patients. For example, right now an average dentist will have, I will just give you an example in Romania, they will have something like 10 20 patients a day. Maybe in US they will have 3-5 patients a day, but when you are taking the money, because we are talking about money, when you are taking the profit that you are making, maybe in US after 3 patients you'll make more money that you having after 20 here in Romania. Why? Because a patient in US maybe will go to the dentist and need actual work like a composite filling once every 5 years. Here, maybe a patient, you will see it every month because they will have multiple problems because there is almost zero prevention done. And for the patient, the cost in the end will be much, much higher. The dentist also will not be that happy because it's much nicer to have only 3 patients a day than compared to 20. You can have more attention for every one of them. You can have more free time for you and go to congresses, go to wherever you like, maybe use that time for yourself or just make more education for you and the rest of the world.
Well, yes, but I went to my dentist on the way to the airport for this trip for a hygiene appointment. I go every 4 months now because I have caries in my mouth and I need to have that hygiene appointment, and now they've identified me as more caries prone. But I'm interested, I want to go, not just because I work in the field of dentistry, but because they've shown me how my health is better as a result of care. My dentist has a fairly successful practice. There's 2 dentists and there's 3 hygienists in that practice. My dentist sees 10 patients a day and he practices 5 days a week. His partner sees 10 to 12 patients a day and he practices 5 days a week, but his partner usually works on the Saturday as well. So it's actually the rare dentist who's seeing just 3 patients a day, and especially 3 to 5, only once in a while. They still find they need to see patients to earn enough money to live and pay for their education. Because in the United States now today, the average dental student graduates with just under $300,000 of student debt. Yeah. Whereas here in Romania, I think that it's all for free, and you don't have that debt burden, which is a fantastic choice or a fantastic opportunity. But the idea that if I do preventive work, it's going to limit what's going to be done in the future is absolutely false. It's a concern, I understand, but it's a concern not supported by data. The data says that won't happen. So I go regularly. I have good dental care. I still have abfractions in my teeth, so I need some restorative work on the facial surfaces. I have old amalgams that are beginning to fail. They've been in place for a long time, but they're beginning to fail. So I have additional restorative work on a regular basis. I believe that at least every other year, I'm having some restorative work being done. In fact, earlier this year, I had my 2nd crown. I have no root canals in my mouth. I have but two crowns now, and I have a series of, I still have old amalgams, and I have a series of composite treatments as well. So I'm having regular care despite having regular restorative work done in my mouth, despite having really good dental care. But I don't lose teeth as a result unless they were extracted intentionally. I lived in England for a number of years, and my wife is English. Back as recently as the middle 1970s, it was still common to receive, in the industrial north of England, it was still common to receive as a dowry present full dentures. Because extract all your teeth when you're in your early 20s and you'll never have dental problems. And we now know you only increase the amount of oral health problems that you have. You may not have
systemic one because you'll have all digestive.
All kinds, all directly related to each other. So my passion about preventive dentistry is that it's a way to increase systemic health. It is not a way to reduce dentistry. More dentistry will be performed because patients know that they're receiving great care. They are are having less caries, but they want their smiles to look more beautiful. And people are spending the money to have that optional treatment done on them so they look more beautiful. That's sort of the benefit of a developing economy and developing society, is that I reach a certain level of my health, and now I want it to look better and feel better. And now I can afford to do more of that. So I think Romania has that same level of development from 20 years ago to today. It's a significantly more developed economy and higher expectations from the consumer's point of what they want across all phases of their life, including their health and their oral health. So I would have to argue strongly against the idea that doing prevention is going to reduce the need for dental care in the future. I think it will only increase the amount of care that any one dentist provides.
So prevention will not reduce the number of the patient for the dentist. As a matter of fact, everyone knows on this world that the well-known Hollywood smile, basically teeth really nice, really wide. US, it's a leader right now on prevention, but also it's a saying in US that if you are really, really rich, you are either a lawyer or a dentist.
Yeah.
So even if the dentists are in US, it's a lot of prevention. The dentists are still making a lot of money. They still have a lot of patients. Yeah. Where should we start here in Romania with prevention? Should we start with the patient? Should we start them, teach them in schools? How important is the prevention? Should we teach more the dentists?
So, whilst it should happen at all levels, I believe it happens in the dental office first. If the dental team doesn't appreciate the role of prevention in increasing health and also increasing the amount of dentistry that will be done over the lifetime of the patient, then they will not talk about prevention. And when the patient brings it up, they won't answer it in an enthusiastic way. They'll answer in a manner that the patient says, maybe I don't need to do that. And we don't usually choose to go to the dentist and say, do whatever you want.
Yeah.
I go there because I believe it's important to come on a regular basis or because I have a problem. If I have a problem, it's a time to get the patient moving in the right direction in oral health care. If I go there on a regular basis, I'm going to keep on going even though I need additional restorative care because I value the health of my mouth. I value the appearance of my mouth. And the people who help me understand that is my dentist. So I believe you start with the dental team. Certainly at the dental schools or in the hygiene schools, it's important as well. And even though we tend to view this as if an office has a hygienist, it's the hygienist's responsibility. They only take it as their responsibility if the dentist first says, yes, this is important, and we will do great preventive care as part of our delivery of great oral health care to our patients. And then the hygienists will feel free because it's an improved style of this practice. And then they recognize they are working in a progressive practice where patient health comes before other considerations. And healthy patients generate more revenue for the dental office.
We spoke about education. Dentists and patient alike. I know Centrix is involved in education programs. I know it's really, really active. For example, it was in Roots in Berlin. It will be now on Endo Days in Romania. Dr. Daniel Cerny from the Czech Republic will be here, and it has a great presentation about post-endodontic treatment. How is Centrix so active in this area, and what you are doing right now with the webinars, with the launch and learns, because
it's an important area. There are so many different products available to a dentist to use. How do they understand the differences in products if education is not provided? I can certainly provide education that is basically marketing, and it tells you great things about my product, whether it's fact-based or not. My preference is that we provide continuing education credits with it, which means the material has to be reviewed and that it's scientifically based and that it's supported by data, as opposed to just marketing or sales information. So we have been building a series of in-office education programs that, at least in the United States, will provide continuing education credits. So that's an important area. Another important area is to be able to do all this online or digitally. In the United States, digital education is starting to overwhelm live education. It just makes better use of the dentist's time. One of the reasons I wanted to come here was Dentstore has this fantastic educational studio and has the ability to share this information from manufacturers, from scientists, from dental schools to their customers. And their belief is that an educated customer not only does better dentistry, but recognizes the value that a distributor like Dentstore is in helping them grow and become a more profitable dental practice. This is a fantastic facility. I have to admit there are few dental distributors and even few manufacturers around the world who have both the sophistication of facilities and have the understanding of the need for these facilities as I've seen here at Dentstore. So this is a fantastic facility, and this company is only to be congratulated for that. But we too are making use of facilities like these. I know you do a lot of education from this facility, and we want to be able to share what we have or also work together with companies like Dentstore so that we can provide more education to the dentist, so that whether it's 10 o'clock at night or when I'm home having a cup of coffee, or it's 10 o'clock in the morning and I have a patient in the chair, if I don't understand something or I want more information about it, I can go online and quickly gather the information I need to have so that I, again, am delivering the best possible care. In the old days, this was not possible. I'd have to wait until the next exhibition or the next Congress took place, and I can go and fill in some knowledge.
And maybe buy a book and search the
yes.
answer in 1,000.
We can read a book.
Yeah, 1,000 pages.
Yeah.
Right now, you just go on the internet, make a search. You can see a video, for example, if it's your first time when you are using a glass fiber post, how you supposed to do it. You just see a video, you see step by steps, and this way you're guaranteed. Again, I use the word guarantee. At least you know that you are doing the right steps.
Yeah.
So education is definitely the future.
It is, and I would only say use the same caution in education as you do in choosing materials. We manufacturers, I would say almost all manufacturers, strive to provide great information. But there's no doubt that some of our information has a bias because they're our products. Yeah. And so we understand that. I think you understand that as well. That's okay as long as when the dentist views this material, they keep that in mind. When you have clinicians like Dr. Czerny, he's a fantastic clinician. And so he's able to come to Endo Days from the Czech Republic. But I can use that same material in the United States. And we like to work with clinicians like Dr. Czerny, like, say, Dr. Zeiss in the United States, and any number of other clinicians who are more expert than we could ever be, to learn from them and modify our products appropriately, and then to share back their information on how to do whatever the topic is more correctly. And where our products fit, fantastic. Where they don't fit, fantastic as well, because there are plenty of choices for the dentist. It's understanding what one wants to do and why, and then being able to do that is very important. You'll find the right products. There are lots of alternatives. Yes, of course, I think that Centrix offers an array of very good products, and we work very hard to make sure they meet both Dr. Dragon's requirements of us, of providing outstanding products that make dentistry easier. Because if we do that, then you'll want to try another Centrix product. But we do this from an education-based approach, a science-based approach, rather than I can make some things and sell them and I hope you'll buy them, whether or not they're good. No, we focus on, does the science say we ought to go in this area? Does the data show that our product works effectively? And do we deliver it in a manner that is usable in the practice?
We started our interview, our discussion today by saying that you work at Coltin and you were responsible of merging between Coltin and Weldent, and You said you had a funny story about that period. Can you share it with us?
So I'm American and I can't help that. When Colteen purchased Whaledent was the market leader in endodontic post, retention pins, and many other metallic devices, and they paired well with many of Colteen's chemistry-related products. And the initial company was going to then be called Whaledent Colteen. Fantastic. Our art department worked on the images for the company, the logos, and how they should look. And so we had Whaledent Colteen. It looked beautiful. We said we'll probably shorten that name, and we should have an alternative. And then we presented the shortened alternative, which was WC, to our Swiss partners. And they said, no, you can't see that, because in America we don't use the phrase WC for toilet.
No.
and in Switzerland and here you do.
Yeah, we do.
Yeah, and we didn't want to have the wrong impression. So on that same day we saw that, and we just said, nope, this is wrong, and we became Colteen Whaledent. And it was Colteen Whaledent for 20-some years, and only recently, in the last 3 years or so, the name Whaledent was dropped, and it's just Colteen.
Colteen right now.
It's shorter, it's easier to remember, so a good move on the company's part for doing that. But we didn't want to have a company that was perceived as a WC.
Yeah, that's true. No one.
Yeah.
I think we'll want that. Thank you a lot for being here today with us. Thank you for sharing from your experience. Thank you for showing us where Romania is as a dental market, comparing with the rest of the world, with US and the rest of the Europe.
Yeah.
Once again,
it's my pleasure, and it's always a pleasure to be here in Romania. I know if I had a dental problem today, I could go get myself treated here as well as I could do that in New York. That's not a concern of mine. The concern is only on an ongoing basis. What is the dentist able to do and make enough profit to live properly, to pay their staff and take care of the team, so that it's a financially viable opportunity. I think dentistry is a great profession. I still encourage my son to go to dental school, and I hope that he'll take me up on that, but that's for the future.
We are waiting here for you with a big next innovation that you'll have, I hope, really soon. Once again, thank you a lot for being with us today. It was a pleasure.
Thank you.
Thank you.
My pleasure. Thank you.
Bye.